and the membership form. Please join. And this time the annual 8th conference will be going to be held in Kochi. So I welcome all of you to Kochi as an outing and Kerala tour program also. So most of the topics we already covered the coronary artery disease. So I will point out few things that if cardiac status is normal in the acute phase of KD, in general, no significant late major cardiac complications observed actually. So there are complications like acute complications and late complications. These acute complications, when you encounter, definitely your pediatricians have a doubt whether you should diagnose as a KD with the two criteria. Then definitely you have to add up to these two criteria and make it as confirmed diagnosis of incomplete KD and start treatment early. That's the reason we suggest that the ECG and echocardiogram, if it is available, if pediatric cardiologists are nearby, please suggest for an echocardiogram. We are not expecting coronary artery dilatation, but sometimes associated, as we heard yesterday, it's a pancarditis. Sometimes evidence of valvulitis or AR, MR or myocarditis, LV dysfunction. This also can add as a heart involvement in Kawasaki disease. Not necessary, not necessary coronary artery involvement to add. If the criteria 1 or 2 are there, definitely if you are seeing evidence of myocarditis or valvulitis, then you should start on treatment. So there are acute cardiac complications, vasculitis, myocarditis, endocarditis, coronary ectasia, heart failure, KD shock syndrome, valvulitis, conduction system abnormality, because all the conduction systems are just beneath the endocardium. So anything happen to any inflammation to the myocardium or endocardium, this conduction system also can be affected. Different arrhythmias can be presented. So the late cardiac complications, as you know, we already heard, I'm not going to touch. Thrombosis, aneurysm rupture, myocardial infarction, calcification, premature atherosclerosis. And remember, after 10 years only, atherosclerosis process can occur. So below 10 years, if any child come and ask, sir, can I eat egg and ice cream, etc., I freely suggest you take. Don't worry. But after 10 years, there will be a slowly starting atherosclerotic changes in the edema. So that is the reason some of the cases, whether the statin has to be continued or not. So pointing out this myocarditis in KD, remember myocarditis is a well-recognized component of Kawasaki disease with left ventricular dysfunction. That's the reason I say that the early echocardiogram is really advisable, but the trained people can recognize early. So when you suggest a echocardiogram, most of the time adult cardiologists are doing, so that you just simply write, please rule out MR, TR, and calculate the ejection fraction, any effusion. You just simply point out so that the adult cardiologist also will stress on that particular point, even though they have not seen any Kawasaki disease. They will write, sir, there are mild TR, AR, MR are seen, or mild effusion are seen, or EF is borderline 60. Below 60 is normal for children. And below 60 is abnormal, above 60 is normal. In adult is below 55 is abnormal, above 55 is normal. So borderline, never rely on MOD. I suggest you, because MOD is outdated by us for our Indian Echocardiography Society and worldwide literature. If you see, MOD is outdated. if you don't have the software for global strain echo in your echocardiographic machine, at least everyone knows, cardiologists and MD people are knowing that how to calculate EF by Simpson method. You can write it on the paper while you are addressing to cardiologist, calculate the EF by Simpson method. So the borderline EF also you should be careful with the rising titer of the N-pro-BNB. You consider as a subclinical myocarditis. If the EF is low and with the rising titer of the N-pro-BNB, definite evidence of myocarditis. So in KD, myocarditis develop even earlier than the epicardial coronary arteritis. It peaks by this is day 10 and then disappears gradually after day 20. So inflammatory cell infiltration consisting mainly of lobulated leukocytes and large mononuclear cells was seen in the myocardial interstitium in all cases. So clinical exam also very important thing. Know that clinical auscultation is a dying art. Nobody want to do nowadays with a stethoscope. Even in our ward also, juniors are never carrying the stethoscope at all. They are not, even in the outpatient department, nobody is allowing the child to in a supine position and examining. This was had actually. Simply open up the mouth with a torch, seeing the throat and writing some medication. No. Clinically, you never, you have to examine head to toe. Then only you can identify the axillary pulsatile aneurysms or any the femoral artery occlusion, etc. Lot of things has to be find out. Clinical examination is very important thing. So gallop, tachycardia, tachypnea, pericardial rub, evidence of congestive heart failure, liver examination. Nobody is doing that nowadays. Palpation of the liver. No. It's so sad actually. Everybody looking at the X-ray, okay, pneumonia, okay, start on antibiotic. No, that practice has to be stopped and we have to, clinical examination is very important thing. Otherwise your next generation will be totally out. Most often acute phase will be in subclinical phase. That's what I said. If the rising titer of N-pro-BNB and evidence of some valvulitis and EF is in a borderline 58 or 57, I consider like a subclinical myocarditis. Definitely we will start on treatment. So this is the initial time, some 4 cases they published and they found that all cases had EF was reduced to 44 to 51. And ECG changes, as I said yesterday, the ECG also important thing that early pericarditis can be detected, so that even that also you can add. The pediatrician had only 2 criteria are whether we should include in incomplete or complete or whether we should diagnose KD or not. Then I say that it's not necessary, that is my opinion, it's not necessary coronary artery is involved, then only you can add 2 plus 1 so that 3 by 5 consider as incomplete KD and start treatment. If the evidence of thrombocytosis, rising titer of N-pro-BNB, CRP is high, ESR is high, at least eye congestion and redness of the mouth and 2 criteria is already there, then if you are seeing evidence of pericarditis without echocardiogram, then you should say that you start on treatment. If you have a doubt of the financial difficulty, at least they can start on IV MB methylprednisolone. So this is a there are a stage 4 in pericarditis evidence in ECG. Stage 1 is actually easily to detect. That's why I said as soon as you diagnose and admit in the hospital, you please see the ECG. It is easy. There is a sagging of PR segment. And the M pattern, I drawn like this, M pattern, whereas convex elevation is ischemia. And this is the M pattern, if you are seeing, it's evidence of pericarditis. Whereas in stage 2, it will be resolving slowly. and stage 3 T-wave inversion will come. Stage 4 almost like ECG is normal. So early stage 1 you can pick up pericarditis. So this is my case actually one. This is showing that M pattern definite pericarditis. So again the same M pattern I am showing. So definitely MRI is the choice for the gold standard for detecting the myocarditis. But just to rule out myocarditis, we never send the cases for MRI. Severity of detecting edema in myocardium in acute phase of myocarditis is 84% with a specificity of 75%. So multiple foci of the hyper enhancement of myocardium during early gadolinium, Dr. Manful Singh has already discussed all these things, and this is consistent with myocarditis. But clinically, if evidence of N-pro-BNB, N-terminal brain natriuretic peptide. By BNB, the stability is very few hours only. So N-pro-BNB will be little more stable. So that's why N-pro-BNB you have to write very clearly. Sometimes you people are writing BNB only, they will do, lab people are doing BNB only. So in myocarditis, definitely N-pro-BNB you clearly write, and most of the lab will show sometimes higher level, we don't know. That is the reason, very next day I will repeat. If any rising titer is there, definitely evidence. So with the evidence, echo shows some pericardial effusion or EF is borderline or much lower 50% or MR or TR, then definitely you consider as myocarditis. EF is normal and N-pro-BNB is higher, then I consider like a subclinical myocarditis. So diagnosis of myocarditis in children is based on combined, including lab, echo and confirmatory investigations. So this slide I myself made with H&E stain during my immune complex vasculitis I made in the swine. I inject a horse serum. You know, horse serum will make a type 3 hypersensitivity reaction, and that is the only agent will produce circulating immune complex. So I clearly proved that this is a circulating immune complex vasculitis, whether triggers are SARS-CoV-2 or some other factor, but the pathogenesis will be like a immune complex vasculitis. So you can see the mononuclear and lobulated leukocytes in the pig myocardium. I proved that even myocarditis occurred in the pig muscles also. This we published in the journal. Cardiovascular biomarkers of myocarditis, I already said. High sensitivity TROPI also, or cardiac troponin I, CKMB, and NT-proBNP. And when the titer is average, above 300 picogram, especially with the rising titer, and with the evidence of some ECG changes, suggests that this is a case of a myocarditis. So this normal value, you can take a short note. The neonates, remember, up to 3 days, even up to 6,000 can go up. So don't be panic. And if next day, if you are doing again, it's a rising titer to 7,000 or 8,000, consider. Whereas 3 years to 6 years, above 327 or 350 is significant. Above 350 picogram is significant for 3 to 6 years. Even 12 months to 3 years, also above 600 is significant. So age dependent varies with the N-pro-BNP result. So that you should definitely consider. So these are few just showing some pictures showing the pericardial effusion and the paradoxic motion of the IVS, and global strain is very important thing. For that purpose, we advise to take 3 views. One is a 4-chamber view, 2-chamber view, and 3-chamber view. Now the software of the newer machine automatically will calculate within maximum 3 minutes only will take. So machine also varies. G will give below -20 is significant. In Philips machine, below -25 is significant. That's what we observed. So in this case, definitely this is the Simpson method I showed. You take a dual picture, one is in diastolic period and one is systolic period. You just simply trace it and you get the EF. EF here is 55% and the strain much reduced. Average global strain become minus 11. So this global strain is high sensitive and we can pick up the early myocardial change. So tips for early identification of myocarditis in KD, signs of the heart failure, ESR, CRP, NPRO-BNP, TROPI, and baseline echocardiogram. See for evidence of valvulitis, MR or TR or AR, any evidence of pericardial effusion, EF estimation, mainly by Simpson and global strain study. So I just showed you some slides on myocarditis because already we heard about the coronary artery dilatation, etc. Thank you. Thank you so much.
Thank you, Dr. Sadi. So the next speaker is Dr. Avinash Anatkar.
So, good morning, everyone. I thank you for this opportunity. So, it will be a short talk because primarily it was a hands-on session. So, we'll just run through the slides to see how to assess LV function as a point of care in KD. So, I bring greetings from Pondicherry, and there are certain devices which are now easily available to do a point of care ultrasound. So, most of us are familiar with vendors GE and Philips. So GE provides a V-scan, which is just a handled, just a probe alone comes. So this is the probe. So we can carry it in our pocket and can pair it with our own mobile phones. It's available both in Android and iOS platforms. And on Bluetooth, whatever images we are seeing on in the Echo machine will be on your phone, and you can transfer it in any mode that you wish. And like primarily for our LV function assessment, we'll have the adult probe. Pediatric probe is presently not available, but they have other vascular probe and probes that are used for assessing fetal echo also. So similarly, Philips has brought out their device, so which is being a screen also is provided with them, like which is similar to a iPad. So this is not compatible with the phones, but both are almost at similar cost of around 7 to 8 lakhs. So this will considerably reduce the space occupied in emergencies and will be actually a point of care ultrasound. So how to assess LVEF? A rough assessment will be given by M mode. So we do a parasternal longitudinal long axis, and once the long axis of the LV is obtained, perpendicular cut of the LV is made. Usually the plane is kept distal to the mitral leaflet tips, and once a perpendicular cut is obtained, we can assess the LV cavity size, that is the LV internal dimension in diastole and systole, and the interventricular septum thickness in diastole and systole, and the LV posterior wall thickness in systole and diastole. So the EF given by this method is the Teichholz method. As Professor Sajay Phillips mentioned, it is not the recommended method now. but it can roughly give you an idea of the EF by eyeballing, and we can get a rough estimate if there is a LV dysfunction in a particular child or not. So the problem with this method it assesses the LV at a single point. So supposing a child is having a myocarditis, it may not have a global LV dysfunction. Certain patchy areas of myocarditis might be there. So supposing we take a LV cut at a different point, we may wrongly allude that the LV function is normal, and when actually there is a LV dysfunction. So LVEF by Simpson's method is the ideal method, and most of us are familiar with doing that. So there are two portions of the Simpson's method. So apical 4-chamber view in end diastole and end systole, and apical 2-chamber in end diastole and end systole. So the 4-chamber view is going to give us the single plane Simpson's EF, and when we do the apical 2-chamber additionally, it gives you the biplane EF. So ideal is to do the 3D EF so that it gives the complete spherical volume of the LV, and we get the EF. But this is at least equivalent in that 2 frames of the LV function is assessed by the biplane Simpson's method. So the LV is divided into 20 discs so that it gives the volume, the height as well as the width, and the volume of each disc is calculated, and that gives us the rough ejection fraction by Simpson's method. So global circumferential strain, the problem with EF is it is image dependent, and it is also angle dependent. Circumferential strain and longitudinal strain are parameters which have improved upon the EF in that they are angle independent. So if the initial criteria was that ECG was mandatory for acquiring strain, so the images should be ECG gated. But subsequent softwares have evolved now that without ECG also we will be able to get a strain. So in order to get a global circumferential strain, we need to get the LV cut in the parasternal short axis in 3 different planes. So the first plane here shows the at the mitral valve level, so this is at the papillary muscle level, which is the mid LV cut. So here we are able to see the mitral valve level, so that is the basal level, and the subsequent cut is at the apical level. So at these 3 levels we take a LV cut, and then once we do the global circumferential strain, that gives us the GCS at all the levels. And then this is the global longitudinal strain, which is a more accepted parameter compared to the global circumferential strain, and most labs use this parameter to assess the LV function. So here, apical 4-chamber view is taken first, and then the apical 2-chamber view is taken. So all these are at the LV apex. And then the LV 3-chamber view is taken. Sorry. So and then the LV 3-chamber view is taken. So once these 3 views are taken, care should be taken to get at least a minimum of 3 beat acquisition in each of these views. And once this is done, the software gives us the longitudinal strain. So it is not only available for LV, it is also available for RV. Previously, it was not available as a independent software. So we were employing the LV strain for the RV. So RV being a different structure, it was not giving proper values, but now both Philips, Siemens and GE have provided separate strain software for the RV. So this is the RV strain separately for the RVs, particularly useful in children with pulmonary hypertension. I am not aware of its role in KD. LV mass, we can assess LV mass in case of regressed LV, particularly useful in children with transposition of great arteries who are presenting late to assess regressed LV. To assess the mass, we need to feed in the body surface area also so that we get the indexed body mass. So once we begin the echo, if we enter all these parameters, we get a indexed body mass for the child. So it is calculated by the area length method where apical four chamber in end diastole, we get the length of the LV and the mid cavitary width. And in the short axis view at the mid papillary level, tracing is made at the endocardial level and the epicardial level so that the myocardial area is obtained. So then the LV mass is calculated using this formula. So TE index or the myocardial performance index, it is a measure of both the global systolic function and the diastolic ventricular function. It is applicable both for LV as well as RV. So it can be done by two methods. One is by the pulse wave Doppler in the apical 5-chamber view. So once we get the apical 4-chamber view, if a pulse wave Doppler is applied, we will get the mitral inflow here as seen by the E wave and the A wave. And subsequent to that, the mitral valve closure happens, and this is all the events during the mitral closure. So once the mitral valve closure happens, there is a phase where the aortic valve is yet to open. So that is the isovolumic contraction time, that is the IVCT. And subsequently the aortic valve opens and then the LV ejection happens. So that is the LV ejection time. Subsequent to the LV ejection time, there is still a time period where the aortic valve has already closed, but the mitral valve is yet to open. So that is the isovolumic relaxation time, IVRT. And subsequent to that, the mitral valve again opens and then the E wave, that is the early phase where the passive LV filling happens. And after that, the atrial booster pump and then the A wave happens. So if we have a ECG gating, we can time these events. So there is a P wave, and along with the P wave corresponds the A wave of the atrial booster pump. And the end diastole is marked by the QRS complex, and then subsequently the parameters which happen during the mitral closure time, that is the LV ejection, all correspond to the end of T wave, which signifies the end of systole. So this can not only be done with pulse wave, it can also be done using tissue Doppler imaging. But many of the point of care ultrasound devices may not have tissue Doppler imaging. So we must and most of the point of care ultrasounds will have pulse wave Doppler, even if they don't have continuous wave. So applying the pulse wave in a apical 5-chamber view will give a picture where you are able to capture the E wave and the A wave as well as the ejection time if you place the sample volume midway between the mitral valve and the aortic valve. Supposing we place it only at the mitral valve, we get only the mitral inflow parameters. So we'll see this in the hands-on session today. And the normal LV TE index is less than or equal to 0.40. So values above that are significantly abnormal. So we are more interested in regional wall motion abnormality. This is one area in pediatrics like KD, because if there is a giant coronary aneurysm in a particular coronary artery, and supposing the child has had an infarct because of a thrombus, then knowing the regional wall motion abnormality will help us pick up the involved territory. So this is the apical 4-chamber view and the apical 2-chamber view. So apical 4-chamber view, the areas given in green are supplied by the right coronary artery. The areas given, they are the numbers are the LV segments given by the American Society of Echocardiography. So in the 17 segment LV model, what are the numbers? Those correspond to the numbers given here. So the yellow zones are the areas supplied by the left circumflex, and the red zones are the areas supplied by the left anterior descending. So the 17th segment is the true apex, and the 14th is the septolateral. So these are supplied by the LAD. And in the 2-chamber view, the circumflex is not supplying any zone. The entire lateral portion is supplied by the LAD, and the septal portion is supplied by the RCA. And in the parasternal long axis view as well as the apical 3-chamber view, the distribution is similar. So most of the time we try to get a apical 3-chamber view for the LV global longitudinal strain, and in cases where it is not easily possible in certain children, we may opt for the parasternal long axis view, which is a equivalent of the A3C. So the entire posterior wall is supplied by the LCX, and the interventricular septum in this view is supplied by the LAD, and the RV obviously is supplied by the RCA. And in the short axis cuts in the basal LV. So they have given a depiction of the mitral valve in cross section. So the anterior and anterolateral are supplied by the LAD. The inferior and infroseptal are supplied by the RCA, and the lateral and anterolateral are supplied by the LCX in the basal portion. Similarly, in the mid LV, the distribution is similar, LAD, RCA, and LCX, and in the apical LV also, the distribution is similar, whereas the apical cap is supplied by the LAD. So we can give a wall motion score index also in case the wall motion abnormality is identified. So supposing there is normokinesia in each of the 17 segments, so the entire score index will be 17 by 17, so it will be 1. But supposing a child is having hypokinesia in particular area, for instance, this particular example, this child is having a hypokinesia in the apical anterior and apical septal, and in the mid anterior and mid septal. So the score is given as 2 for the zones which are hypokinetic, and the true apex is akinetic. Probably this is the distribution of the LAD territory. So the child has had some problems in the LAD territory, and these have gone into a hypokinetic phase. So, but the true apex is already scarred and it is akinetic. So I mean, summating the scores, this particular child will have a value of 23/17. So any instance where the wall motion score index is more than 1, it is an abnormal score, and there are certain segments which are hypokinetic. And 3 is akinesia, 4 is dyskinesia. Like dyskinesia is where the rest of the LV moves together. For in a systole, all the portions of the LV are contracting together at the same time, whereas one particular segment is going away. So that is dyskinesia. And aneurysmal segment is grossly dyskinetic, and it moves totally abnormally. Most often in the LV true apex, we find aneurysmal LV in case of a LAD related infarction. So this will be the rough assessment of so I don't have direct experience of assessing children with KD and LV function. The closest we have done is multisystem inflammatory syndrome in children. So we assessed the clinical profile and outcomes of this children initially, and that was published in JPCH. And there was a longitudinal follow-up of these children, this cohort, with echocardiography. And we found in GLS, there was a serial assessment of these children at admission, 6 weeks and 3 months, where initially there were segments which were grossly abnormal. This is the entire cohort's LV strain, and subsequently became better by 3 months, but still some portions were abnormal. So summarizing, point of care echo devices are ideal in pediatric setup and emergency setups where we need to screen children for LV function and probably coronary assessment if we have suitable probes for coronary assessment at the bedside. Presently not available with point of care systems. And LV ejection fraction by M-mode is not a great idea, but it gives a rough assessment of the LV, but Simpson's, especially biplane Simpson's, is the recommended method. LV global longitudinal strain is a good parameter, but it's always better to have ECG gating so that even if the particular machine does not have the capability to do a LV strain, a ECG gated DICOM image can be transferred to a workstation, and a strain can be done subsequently. Global circumferential strain is not well validated in children, but the LV myocardial work is the upcoming next thing, where it is like LV strain is angle independent, but it is still load dependent, whereas myocardial work is also load independent. But it's a proprietary item of GE Healthcare, so it is not available with Philips. So, but this may be an upcoming parameter in LV function assessment. So, thanks for your kind attention, and wishing happy learning in the upcoming talks. Thanks.
Thank you, Vilash. We would now move on to the ward for a practical demonstration and hands-on on the echocardiography.